Viruses obligate intracellular parasites. Their replication depends primarily on synthetic processes of the host cell. Therefore, to be effective, antiviral agents must either block viral entry into or exit from the cells or be active inside the host cell. And today, topic is antiviral agents. Look on this slide. You can see viral replication requires several steps. 3 oral nucleoside analogs licensed for the treatment of hepatitis and varicella zoster virus infection. There are acyclovir, valacyclovir, famciclovir. There are drugs for treatment zoster virus infection. There have similar mechanisms of action and comparable indication for clinical use. All are well tolerated. And first drug is acyclovir. This is an acyclic guanosine derivative with clinical activity against 1 type, 2 type, and zoster but it's approximately 10 times more potent agents first and 2 types than against VZV. In vitro activity agents, Epstein-Barr virus, cytomegalovirus, and human herpes virus 6 type is present but weaker. Acyclovir requires 3 phosphorylation steps for activation. Because it requires the viral kinase for initial phosphorylation, acyclovir is selectively activated and the active metabolite accumulated only in infected cells. The bioavailability of oral acyclovir is low. It's near 20% and is unaffected by food. Intravenous formulation is available. Topical formulation produce high concentration in herpetic lesions, but systemic concentration undetectably by this route. Acyclovir is cleared primarily by glomerular filtration and tubular secretion. The half-life is 3 hours in patient with normal renal function. Acyclovir diffuses readily into most tissue and body fluids. Cerebrospinal fluid concentration near 20 to 50% of serum values. Oral acyclovir has multiple uses. In first episodes of genital herpes, oral acyclovir shortens the duration of symptoms by approximately 2 days, the time to lesion healing by 4 days, and the duration of viral shedding by 7 days. In recurrent genital herpes, the time course is shortened by 1 or 2 days when given prophylactically to patient undergoing organ transplantation. Oral or intravenous acyclovir prevents reactive of herpes virus infection. Acyclovir is genitally well tolerated. Now, the diarrhea, headache have occasionally been reported. Intravenous infusion may be associated with reversible renal toxicity, for example, crystalline nephropathy or interstitial nephritis, or neurologic effects, for example, tremors, seizures, delirium. However, they are uncommon with adequate hydration and avoidance of repeat infusion rates. Concurrent use of nephrotoxic agents may enhance the potential for nephrotoxicity. Probenecid and cimetidine decrease acyclovir clearance and increase exposure. Somnolence and lethargy may occur in patients receiving concomitant zidovudine and acyclovir. Next drug, valacyclovir, is the L-valile ester of acyclovir. It's rapidly converted to acyclovir after oral administration by first pass enzymatic hydrolysis in the liver and intestine, resulting in serum levels that are 3 to 5 times greater than those achieved with oral acyclovir and approximate those achieved with intravenous acyclovir. Oral bioavailability is 70%, and cerebrospinal fluid levels about 50% of those in serum. Elimination half-life is 3 hours. Approved uses of valacyclovir include treatment of first or recurrent genital herpes, suppression of frequently recurring genital herpes, as a one-day treatment for oral labial herpes, and as treatment for varicella and herpes zoster. Valacyclovir is generally well tolerated, though nausea, headache, vomiting, or rash occasionally occur. Next drug, famciclovir. After oral administration, famciclovir is rapidly deacetylated and oxidized by first-pass metabolism to penciclovir. It's active in vitro agents you can see in these types of herpes virus. The bioavailability of penciclovir from orally administered famciclovir is 70%. The intracellular half-life of penciclovir triphosphate is prolonged at 7 to 20 hours. Penciclovir is excreted primarily in the urine. Oral famciclovir is effective for the treatment of first and recurrent genital herpes. For chronic daily suppression of genital herpes, for treatment of herpes labialis, and for the treatment of acute zoster viral infection. Oral famciclovir is generally well tolerated, so headache, diarrhea, nausea may occur. Next drug, penciclovir. Guanazine analog penciclovir, the active metabolite of famciclovir, is available for topical use. Penciclovir cream 1% shortens the duration of recurrent herpes labialis or herpes genitalis. Next drug, docosanol. It's a topical docosanol. 10% cream is available without a prescription. Next drug, trifluridine. Trifluorotimidine is a fluorinated pyrimidine nucleoside that inhibits viral DNA synthetase in types one and two types of herpes viral and cytomegaloviral, vaccine, and some adenoviruses. Valomaciclovir is inhibitor of the viral DNA polymerase. Is currently under clinical evaluation for the treatment of patients with acute virus herpes zoster infection, shingles, and acute Epstein-Barr viral infection. It's infection mononucleosis. Infection occurs primarily on the setting of advanced immunosuppression and typically due to reactivation of latent infection. Dissemination of infection results in end organ disease, including retinitis, colitis, central nervous system disease, esophagitis, and pneumonitis. Ganciclovir is a cyclic guanosine analog that requires activation by triphosphorylation before inhibition of the viral DNA polymerase. Ganciclovir has activity agents. You can see in these types viral. Sorry. Ganciclovir may be administered intravenously, orally, or via intraocular implant. Bioavailability of oral ganciclovir is poor. Cerebrospinal fluid concentration, approximately 50% of serum concentration. The elimination half-life is 4 hours, and the intracellular half-life is prolonged at 16 by 24 hours. Clearance of the drug is linearly related to creatinine clearance. The most common side effects of systemic ganciclovir treatment, particularly after intravenous administration, is myelosuppression. Myelosuppression may be additive in patients receiving concurrent zidovudine, mycophenolate, mofetil, and azathioprine. Other potential side effects are fever, rash, diarrhea, nausea, insomnia, headache, and peripheral neuropathy. Central nervous system toxicity, psychiatric disturbance, seizures, confusion, and hepatotoxicity have been rarely reported. Next drug, ganciclovir. It's L-valilester prodrug of ganciclovir that excites a mixture of two gesterones. While ganciclovir is well absorbed and rapidly metabolized in the intestinal wall and liver, to ganciclovir, no other metabolites have been detected. The bioavailability of oral ganciclovir is 60%. It's recommended that the drug be taken with food. The major route of elimination is renal, through glomerular filtration, and active tubular secretion. Side effect, drug interaction, and resistance patterns. There are some of those associated with ganciclovir. Foscarnet, phosphonoformic acid. It's inorganic phosphate analog that inhibit herpesvirus DNA polymerase, RNA polymerase, and HIV reverse transcriptase directly without requiring activation by phospholipase. Foscarnet is available in intravenous formulation only. Poor oral bioavailability and gastrointestinal intolerance preclude oral use. Cerebrospinal fluid concentration are near 67% of steady state serum concentration, as though the mean plasma half-life is 3 to 7 hours. Up to 30% of foscarnet may be deposited in bone with a half-life of several months. Clearance of foscarnet is primarily renal and directly proportional to creatinine clearance. Potential side effects of foscarnet include renal dysfunction, hypo or hypercalcemia, hypo of hyperphosphatemia, hypokalemia, and hypomagnesemia. Anemia, vomiting, nausea, elevation of liver enzymes. There are all side effects, and risk of anemia may be additive in patients receiving concurrent zidovudine. Central nervous system toxicity included hallucination, headache. The risk of seizure may be increased with concurrent use of imipenem. Zidovudine. Cidofovir. Cidofovir is a cytosine nucleotide analog with in vitro activity agents on these viral agents. You can see a lot of viral cidofovir resistant isolates and to be cross-resistant with ganciclovir, but retain susceptibility to foscarnet. Also, the terminal half-life of cidofovir, approximately 2.6 hours, the active metabolite cidofovir diphosphate has prolonged intracellular half-life of 70 by 265 hours, thus allowing infraurgent dosing. Elimination is by active renal tubular secretion. High flux hemodialysis reduces serum levels of cidofovir by approximately 75%. Intravenous cidofovir is effective for the treatment of cytomegalovirus, retinitis, and is used experimentally to treat adenovirus, human papillomavirus, and poxvirus infections. The primary side effect of intravenous cidofovir is dose-dependent proximal tubular nephrotoxicity, which may be reduced with pregudration using normal saline. Proteinuria, metabolic acidosis, azotemia, and Fanconi syndrome may occur. Concurrent administration of other potentially nephrotoxic agents, for example, amphotericin B, aminoglycosides, non-steroidal anti-inflammatory drugs, foscarnet, pentamidine, should be avoided. Prior administration of foscarnet may increase the risk of nephrotoxicity. So it's all for treatment herpes virus. Next group of drugs, antiretroviral agents. Substantial advances have been made in antiretroviral therapy since the introduction of the first agent, zidovudin, in 1987. Administration of combination antiretroviral therapy, typically comprising at least 3 antiretroviral agents, has become the standard of care. Viral susceptibility to specific agents varies among patients and may change with time owing to development of resistance. Nucleoside and nucleotide reverse transcriptase inhibitors. This drug act by competitive inhibition of virus immunodeficit of human first type reverse transcriptase. In comparison into the growing viral DNA chain causes premature chain termination due to inhibition of binding with the incoming nucleotide. Each agent requires intracytoplasmic activation via phosphorylation by cellular enzymes to the triphosphate form. Look, first drug, abacavir. It's guanazine analog that is well absorbed following oral administration, is near 83% and is unaffected by food. The serum half-life is 1.5 hours. The drug undergoes hepatic glucuronidase and carboxylation. Cerebrospinal fluid levels approximately 1/3 those of plasma. Abacavir is often co-administered with lamivudine, and once daily fixed dose combination formulation is available. Abacavir is also available in fixed dose combination with lamivudine and zidovudine. High level resistance to abacavir appears to require at least 2 or 3 concomitant mutation, and those tends to develop slowly. Symptoms which generally occur within the first 6 weeks of therapy include fever, nausea, fatigue, vomiting, abdominal pain, and diarrhea. Respiratory symptoms such as dyspnea, pharyngitis, cough may also be present, and skin rash occurs in about 50% of patients. Abacavir should be used cautiously in patients with existing cardiac risk factors due to possible increased risk of myocardial events. Since abacavir may lower methadone levels, patients receiving those two agents concurrently should be monitored for signs of opioid withdrawal and may require increased dose of methadone. Didanosine, a synthetic analog of deoxydenazine. Oral bioavailability is approximately 40%. Dosing on empty stomach is optimal, but buffered formulation are necessary to prevent inactivation by gastric acid. Cerebrospinal fluid concentration of the drug approximately 20% of serum concentration. Serum half-life is 1.5 hours, but the intracellular half-life of the activated compound is long as 20 hours. The drug is eliminated by both cellular metabolism and renal excretion. The major clinical toxicity associated with Didanosine therapy is dose-dependent pancreatitis. The risk, peripheral distal sensory neuropathy. Another potential toxicity may be increased with concurrent use of stavudine, isoniazid, vincristine, ribavirin. Other reported adverse effects include diarrhea, particularly with the bufferate formulation, um, and hepatitis, esophageal ulceration, cardiomyopathy, central nervous system toxicity, it's irritability, insomnia, headache, and hypertriglyceridemia. Previously asymptomatic hyperuricemia may prescripted attack of gout in susceptible individuals. Concurrent use of allopurinol may increase levels of didanosine. Next drug, emtricitabine. It's fluorinated analog of lamivudine with a long intracellular half-life, more than 24 hours, allowing for once daily dosing. Oral bioavailability of the capsules is 93% and unaffected by food, but penetration into the cerebrospinal fluid is low. The serum half-life is about 10 hours. Oral solution, which contains propylene glycol, is contraindicated in young children, pregnant women, patients with renal or hepatic failure, and those using metronidazole and disulfiram. The most common side effect observed in patients receiving emtricitabine, headache, nausea, rash, and diarrhea. No drug-drug interaction of note have been reported to date. Lamivudine. It's cytazine analog with in vitro activity agent to first type viral that is synergistic with a variety of antiretroviral nucleoside analog, including zidovudine and stavudine agents, both zidovudine sensitive and zidovudine resistance first type viral strains. Oral bioavailability exceed 80% and is not food dependent. Serum half-life is 2.5 hours, whereas the intracellular half-life of the triphosphatidylate compound is 11 hours. Most of the drug is eliminated on changing in the urine. Lamivudine is often co-administered with abacavir, and once daily fixed dose combination formulation is available. Lamivudine is also available in fixed dose combination with zidovudine, either alone or in combination with abacavir. Potential side effects are dizziness, headache, insomnia, dry mouth, fatigue, and gastrointestinal discomfort. So they are typically mild and infrequent. Short-term safety of lamivudine has been demonstrated for both mother and infant. Stavudine. The timidine analog stavudine has high oral bioavailability that is not food dependent. The serum half-life is 1 hour, the intracellular half-life is 3 hours, and mean cerebrospinal fluid concentration 55% of those of plasma. The major toxicity dose-related peripheral sensory neuropathy. The incidence of neuropathy may be increased when stavudine is administered with other neuropathy, including drugs such as zolcitabine, vincristine, isoniazid, ribavirin, or in patients with advanced immunosuppression. Symptoms typically resolve discontamination of stavudine. In such cases, reduces dosage may be continuously restarted. Other potential side effects, there are pancreatitis, arthralgia, and elevation in serum aminotransferase. Tenofovir. It's acyclic nucleoside phosphonate, for example, nucleotide, analog of adenosine, like the nucleoside analog, tenofovir competitively inhibition HIV reverse transcriptase and causes chain termination after incorporation into DNA. The oral bioavailability in fasted patient is approximately 25% and increases to 39% after a high-fat meal. Prolonged serum and intracellular half-life allow once daily dosing. Elimination occurs by both glomerular filtration and active tubular secretion. Tenofovir associated with decreased fetal growth and reduction of fetal bone adiposity in monkeys. There is significant placental passage in humans. Zolcitabine. It's cytosine analog with high oral bioavailability, near 87%, and serum half-life of 1 by 2 hours. Intracellular half-life of 2.6 hours necessitates thrice daily dosing, which limits its unusefulness. Plasma levels decrease by 25% when the drug administered with food or antacids. The drug is extracted renally. Cerebrospinal fluid concentration approximately 20% of those in the plasma. Zolcitabine therapy is associated with a dose-dependent peripheral neuropathy, but appears to be slowly reversible if treatment is stopped promptly. Headache, rash, nausea, and arthralgias may occur but tend to be mild or resolve during therapy. Next drug, zidovudin. It's deoxytimidine analog that's well absorbed and distributed to most body tissues and fluids, including cerebrospinal fluid, where drug levels are 60% of those in serum. Also, the serum half-life average 1 hour. The intracellular half-life of the phosphorylation compound is 3 hours, allowing twice daily dosing. Zidovudin eliminated primarily by renal excretion following glucuronidation in the liver. Zidovudin available in fixed dose combination formulation with lamivudin as an alone or in combination with abacavir. Zidovudin was the first antiretroviral agent to be approved and has been well studied. The drug has been shown to decrease the rate of clinical disease progression and prolong survival in viral infected individuals. Efficacy has also been demonstration in the treatment of HIV-associated dementia and thrombocytopenia. Less common toxicity include thrombocytopenia, hyper um, uh, no, myopathia. High dose can cause anxiety, confusion. Zidovudine may decrease phenytoin levels. It's drug-drug interaction. Next, drugs group. The binding site of NNRTI and shortening non-nucleoside reverse transcriptase inhibitors, NNRTIs. It's near to but distinct from that of NRTIs. Unlike the NRTIs agent NNRTIs, neither compete with nucleoside 3-phosphate nor requires phosphorylation to be active. For the elimination to use of NNRTI agent as component of antiretroviral therapy is the metabolism by the cytochrome P system leading to innumerable potential drug-drug interaction. All agent substrates for cytochrome 3A4 and can act as inducers, nevirapid inhibitors, delavirdine, or mixed inducers and inhibitors, efavirenz, etravirine. Given the large number of non-HIV medication, there are also metabolized by this pathway. Drug-drug interaction must be expected and looked for. Dosage adjustment frequently required and some combination contraindicated. Delavirdine has oral bioavailability of about 85%, but this is reduced by antacids or blockers of H2 receptors. It's extensively bound near 98% to plasma potential and has correspondingly low cerebrospinal fluid levels. Serum half-life is 6 hours. Skin rash occur in up to 40% of patients receiving delavirdine. It typically occurs during the first weeks of therapy and doesn't preclude retrenchment. Other possible side effect nausea, diarrhea, headache, increased serum aminotransferase levels. And delavirdine extensively metabolized by the cytochrome 3A and 2D6 enzymes and also inhibits 3A4 and 2C9. Next drug, efavirenz. It can be given once daily because of its long half-life near 40 hours. It's moderately well absorbed following oral administration. Signs toxicity may increase owing to increased bioavailability After a high-fat meal, efavirenz should be taken on empty stomach. Efavirenz is principally metabolized by 3A4 and 2B6 to an active hydroxylate metabolite, cytochrome. The remainder is eliminated in the feces. Unchanged drug, it's highly bound to albumin, 99%, and cerebrospinal fluid levels range from 1% of plasma levels. In principal adverse effect, you can see on slide. Next drug, nevirapine. Oral bioavailability of nevirapine is excellent, more than 90%, and is not food dependent. The drug is highly lipophilic and achieves cerebrospinal fluid levels that are 45% of those in plasma. Serum half-life is 30 hours. It's extensively metabolized by cytochrome 3A, is a form to hydroxylated metabolized and then excreted primarily in the urine. Not teratogenicity. Protease inhibitors. The HIF protease is responsible for cleaving those precursor molecules to produce the final structural proteins of the mitochondrial core. By prevention post-translation cleavage of the jet pol polyprotein protease inhibition PIS prevents the processing of viral proteins into functional conformation, resulting in the production of imatin non-effective viral parts. Atazanavir, yes, atazanavir is as a peptide PI with a pharmacokinetic profile that allows once daily dosing. It should be taken with lime meal to enhance bioavailability. Atazanavir requires acid medium for absorption and exhibit pH-dependent aqueous solubility, therefore separation of ingestion from acid-reducing agents by at least 12 hours is recommended, and concurrent proton pump inhibitor are contraindicated. Azatanavir is able to penetrate both the cerebrospinal and seminal fluids. The plasma half-life is 6 hours, which increases to approximately 11 hours when co-administered with ritonavir. The primary route of elimination is biliary. Atazanavir should not be given to patients with severe hepatic insufficiency. Atazanavir may be associated with prolongation of the electrocardiographic PR interval, which is usually inconsequentially but may be exacerbated by other causative agents such as calcium channel blockers, and may result in atrioventricular block. QT prolongation is another potential electrocardiographic effect of atazanavir, but is rarely clinically significant. As inhibitor of cytochrome 3A4 and cytochrome P2C9, the potential for drug-drug interaction with atazanavir is great. Darunavir must be co-administered with ritonavir. Darunavir may be administered once daily in treatment patient symptomatic adverse effect. Darunavir included diarrhea, headache, nausea, and rash. Laboratory abnormality included dyslipidemia and increases in amylase and hepatic transaminase levels. Liver toxicity, including severe hepatitis, has been reported in some patients taking Darunavir. The risk of hepatotoxicity may be higher for persons with hepatitis B and C or other chronic liver disease. Darunavir contains sulfonamide moiety and should be used continuously in patients with sulfonamide allergy. Darunavir both inhibits and metabolized by cytochrome P3A enzyme system, conferring many possible drug-drug interactions. In addition, the co-administered ritonavir is potential inhibition of cytochrome P3A and cytochrome P2D6 and inducer of other hepatic enzyme systems. Osamprenavir is prodrug of amprenavir that's rapidly hydrolyzed by enzymes in the intestinal epithelium. Because of its significantly lower daily pill burden, Fosamprenavir tablets have replaced amprenavir capsules for adults. Fosamprenavir is most often administered in combination with low-dose ritonavir. Amprenavir is rapidly absorbed from the gastrointestinal tract, and its prodrug can be taken with or without food. However, high-fat meals decrease absorption, and those should be avoided. Plasma half-life is relatively long, it's near 11 hours. Amprenavir is metabolized in the liver by cytochrome P3A4 and should be used with caution in the setting of hepatic insufficiency. The most common side effect of drug, there are headache, nausea, diarrhea, peripheral paresthesias, depression, and rash. Up to 3% of patients may experience rashes, including Stevens-Jones syndrome, several announced to warrant drug discontinuation. Indinavir requires acidic environment for optimum solubility and therefore must be consumed on empty stomach or with a small, low-fat, low-potential meal for maximal absorption. The serum half-life is 2 hours. Potential binding is approximately 60%, and the drug has high level of cerebrospinal fluid penetration. Excretion is primarily fecal. Most common side effect individual hyperbilirubinemia, nephrolithiasis, thrombocythemia, increased serum aminotransferase, nausea, dry skin, diarrhea, insomnia. Next drug. Lopinavir is currently formulated only in combination with ritonavir, which inhibits the cytochrome P3A mediated metabolism of lopinavir therapy, resulting in increased exposure to lopinavir. In addition to improved patient compliance due to reduced pill burden, lopinavir-ritonavir is generally well tolerated. Lopinavir should be taken with food to enhance bioavailability. The drug is highly protein bound and its half-life is 6 hours. Metabolized by cytochrome 3A, which is inhibited by ritonavir. Serum levels of lopinavir may be increased in patients with hepatic impairment. The most common adverse effect of lopinavir diarrhea, nausea, abdominal pain, and other. Potential drug-drug interaction are extensive. Nelfinavir has high absorption in the fat state, underdose metabolism by cytochrome P3A, and excreted primarily in the feces. The plasma half-life in humans 5 hours, and the drug is more than 98% potential protein point. Most common adverse effects associated with nelfinavir are diarrhea and flatulence. Diarrhea often respond to anti-diarrhea medication but can be dose-limiting. Nelfinavir, inhibitor of the cytochrome P3A system, and multiple drug interaction may occur. Ritonavir has high bioavailability. They increase with food. It's 98% protein bound and has serum half-life of 5 hours. Metabolism, active metabolite occurs via the cytochrome P3A and 2D6 isoforms. Excretion primarily in the feces. Caution is advised when administered the drug to a person with impaired hepatic function. Potential side effect of ritonavir, particularly when administered at full dosage, gastrointestinal dysfunction, paresthesia, elevated serum aminotransferase levels, headache, nausea, vomiting, diarrhea, abdominal pain. Ritonavir is a potent inhibitor of cytochrome P3A4, resulting in many potential drug interactions. Saquinavir. In its original formulation as a hard gel capsule, oral saquinavir was poorly bioavailable. However, reformulation of saquinavir H for once daily dosing in combination with low-dose ritonavir has both improved antiviral efficacy and decreased gastrointestinal side effect. Saquinavir is 97 protein bound, and serum half-life is 2 hours. Excretion in the feces. Reported adverse effects include gastrointestinal discomfort and rhinitis. When administered in combination with low-dose ritonavir, there appears to be less dyslipidemia or gastrointestinal toxicity than with some of the other boosted PI regimes. Tipranavir. It's used in combination with ritonavir to achieve effective serum levels and is not approved for treatment of patient. Bioavailability is poor but is increased when taken with high-fat meal. The drug is metabolized by the liver microsomal system and contraindicated in patients with hepatic disease. Tipranavir contains sulfanilamide moiety and should not be administered to patients with no sulfa allergy. The most common adverse effect from tipranavir nausea, diarrhea, vomiting, and abdominal pain. And 3 inhibitors. Chemical receptor binding induces further conformation changes in group 140 allowing. So with the host cell membranes and subsequent entry the viral core into the cellular cytoplasm. And first drug is enfuvirtide, which must be administered by subcutaneous injection, is the only parenterally administered antiretroviral agent. Metabolism appears to be by proteolytic hydrolysis without involvement of the cytochrome system. Elimination half-life is 3 hours. The adverse effect with enfuvirtide therapy, local injection site reaction, consisting of painful and erythematous nodules. Other symptomatic side effects may include headache, insomnia, dizziness, and nausea. Hypersensitivity reaction may rarely occur, varying severity, and may recurrent rescheduling. No drug-drug interaction have been identified that would require the alteration of the dosage of concomitation antiretroviral or other drugs. Maraviroc. Absorption of Maraviroc is rapid by variable with the time to maximum absorption generally being 4 hours after inhalation of the drug. Recommended dose of Maraviroc varies according to renal function and the concomitant use of cytochrome P3A inducer or inhibitors. Integrase strand transfer inhibitors raltegravir. Absolute bioavailability of raltegravir has not been established, but doesn't appear to be food dependent. The drug is metabolized by glucuronidation and doesn't interact with the cytochrome P system. Therefore, it's expected to have fewer drug-drug interaction than many of the other antiretroviral agents. Potential side effects of raltegravir include insomnia, headache, nausea, diarrhea, and dizziness. Increases in creatine kinase may occur with potential myopathy and rhabdomyolysis. There is minimal affection serum lipids. And look on the slide, new antiretroviral agents, and new therapeutic continually being so that exploit other target have activity agent resistant viral strain have a lower incidence of side effect and offer convenient dosing. In addition, new drug classes such as maturation inhibitors, Bevirin, MAT, under investigation. So it's all about treatment human immunodeficit virus. And next hope draft, antihepatitis agents. Several agents, effective agents, hepatitis B and C are now available. Current treatment is suppressive rather than curative, and the high prevalence of this infection worldwide with their concomitant morbidity and mortality reflect critical need for improved therapeutics. First drug, interferon alpha. Interferon hosts cytokines that extend complex antiviral immunomodulatory and anti-proliferative actions. Injectable preparation of interferon alpha available for treatment of both hepatitis infection, interferon alpha 2 al A and interferon alpha 2B may be administered either subcutaneously or intramuscularly. Interferon alpha con 1 is administered subcutaneously. Elimination half-life is 5 hours for interferon alpha 2A and 2B, depending on the route of administration. Half-life of interferon alpha con 1 in patients with chronic hepatitis C ranges from 2 hours. Alpha interferons filtrated at the glomerular and undergo rapid proteolytic degradation during tubular absorption, such that detection in the systemic circulation is negligible. The side effects of interferon alpha include flu-like syndrome, it's a headache, fever, chills, myalgia, and malaise. They typically occur within 6 hours after dosing. This syndrome occurs in more than 30% of patients during the first week of therapy and tends to revolve upon continued administration. Contraindication to interferon alpha therapy include hepatic decompensation, autoimmune disease, and history of cardiac arrhythmia. This translates into suppression of hepatitis B DNA to undetectable levels, seroconversion to HBe agent, or more rarely, from positive to negative, and reduction in elevated hepatic transaminase levels. This points correlated with improvement in necroinflammatory disease and decreased risk of hepatocellular carcinoma and cirrhosis, and decreased need for liver transplantation. Several anti-HIV agents have anti-HIV activity as well, including lamivudine, adenofavir, dipivexil, and tenofovir. Adefovir, dipivoxil. Two drugs. Adefovir, dipivoxil is a diester prodrug of adefovir, an acyclic phosphonate adenine nucleotide analog. It's phosphorylated by cellular kinase to the active diphosphate metabolite and competitively inhibits DNA, hepatitis B virus polymerase, and causes chain termination after incorporation into viral DNA. Oral bioavailability of adefovir dipivaxin about 60% and unaffected by meals. It's rapidly and completely hydrolyzed to the parent compound by intestinal and blood esterase. Protein being is low up to 5%. Intracellular half-life of the diphosphate is prolonged, ranging from 5 to 18 hours in various cells. This makes once daily dosing feasible. Adefovir is excreted by combination of glomerular filtration and active tubular secretion and sequence dose adjustment for renal dysfunction. However, it may be administered to patients with decompensated liver disease. Entecavir is orally administered guanosine nucleoside analog that competitively inhibits all three functions of viral B hepatitis DNA polymerase, including base priming reverse transcription of the negative strand and the synthesis of the positive strand DNA. Oral bioavailability approaches 100%, but is decreased by food. Therefore, entecavir should be taken on empty stomach. The intracellular half-life of the active phosphorylated compound is 15 hours. It's excreted by the kidney. The most frequent adverse effect dizziness, nausea, and headache. Lamivudine. Pharmacokinetics of lamivudine described earlier. Lamivudine can be safely administered to patients with decompensation liver disease. Nausea, headache, and dizziness are rare. Co-infection with immunodeficit viral may increase the risk of pancreatitis. No evidence of mitochondrial toxicity has been reported. Telbivudine is phosphorylated by cellular kinase to the active triphosphate form, which has intracellular half-life of 40 hours. Oral bioavailability is unaffected by food. Plasma protein binding is low and distribution wide. The serum half-life near 15 hours and excretion is renal. There are no known metabolite and no known interaction with the cytochrome P system or other drugs. You can see adverse effect mild. Both uncomplicated myalgia and myopathy have been reported, as has peripheral neuropathy, as with other nucleoside analogies, lactic acidosis and several hepatomegalia with steatosis may occur during therapy, as well as flares of hepatitis after discontinuation. Tenofovir. Maintenance activity agent lamivudine and entecavir-resistant hepatitis virus isolated, but has reduced activity agent adenovirus resistance strains. Emergence of resistance appears to be substantially less frequent during therapy with tenofovir than with adenovirus. Next, compound in clinical development for the treatment of patients with hepatitis B infection includes the nucleoside analogs M3-cytidine and clevudine. As well as the immunologic modulator thymosin alpha, one agents facilitating uptake by the liver using conjugation to ligands and RNA interference compounds. In contrast to the treatment of patients with chronic hepatitis B infection, by primary goal of treatment patient with hepatitis C infection is viral eradication. In clinical trials, the primary efficiency endpoints is typically achievement of sustained viral response, defined as the absence of detectable viremia for 6 months after completion of therapy. Severe is associated with improvement in liver histology, reduction in risk of hepatocellular carcinoma, and occasionally with regression of cirrhosis as well. Drug ribavirin is guanosine analog that's phosphorylated intracellular host cell enzymes. The absolute oral bioavailability of ribavirin is 64%, increases with high fat meals and decrease with co-administration of antacids. Plasma protein binding is negligible, volume of distribution is large, and cerebrospinal fluid levels about 70% of those in plasma. Ribavirin elimination is primarily through the urine. Dose-dependent hemolytic anemia occurs 20% of patients. Other potential side effects: depression, irritability, rash, cough, insomnia, nausea, and fatigue. New agents, among the agents for the treatment of hepatitis C infection, those holding the greatest promise currently are the HCV/NF3 protease inhibitors, telaprevir and boceprevir. This highly potent agent likely to decrease the overall duration of the therapy with possible greater tolerability than current regimes. Another class of promising agent is 5B polymerase inhibitors, including both nucleoside and non-nucleoside analog. Next group of drug, anti-influenza agents. Influenza virus strains are classified by their core proteins, for example, A, B, or C, species of origin, for example, avian, swine, and geographic site of isolation. Influenza A, the only strain that causes pandemics, is classified in 16H, gamma-glutamine and 9N neuraminidase. No subtypes based on surface proteins. Also, influenza B viruses usually infect only people. Influenza A viruses can infect a variety of animals' hosts. Current influenza A subtypes, there are circulation among worldwide population, including H1N1, H1N2, and H3N2. 15 subtypes are known to infect birds, providing extensive reservoir. Also, while influenza subtypes are typically highly species-specific, they have on rare occasion crossed the species barrier to infect humans and cats. Viruses of the H5 and H7 subtypes, for example, H5N1, H7N7, and H7N3 may rapidly mutate, within poorly flocks from a low to high pathogenic form and have recently expanded their host range to cause both available and human disease. Of particular concern in the avian H5N1 virus, which first caused human infection, resistance to oseltamivir has also increased dramatically. And drug for treatment influenza, oseltamivir and zanamivir. The neuraminidase inhibitors, oseltamivir and zanamivir, analogs of sialic acid, interfere with release of progeny influenza virus from infected host cells, thus halting the spread of infection within the respiratory tract. Those agents competitively and reversibly interact with the active enzyme site to inhibit viral neuraminidase activity at low nanomolar concentration. Inhibition of viral neuraminidase results in clumping of newly released influenza virions to each other and the membrane of the infected cells. So the duration of illness is decreased by 1-2 days compared with those on placebo. Severity is diminished and the incidence of secondary complication in children and adults decreases. Once daily prophylaxis is 90% effective in preventing disease after exposure. Oseltamivir is an orally administered prodrug that is activated by hepatic esterases and widely distributed throughout the body. Oral bioavailability is 80%, plasma protein binding is low, and concentration in the middle ear and sinus fluid are similar to those in plasma. Half-life of oseltamivir is 10 hours and excretion is by glomerular filtration and tubular secretion in the urine. Potential adverse effects include nausea, vomiting, and abdominal pain, which occur in 10% of patients early in therapy, but tend to resolve spontaneously. Zanamivir is delivered directly to respiratory tract via inhalation. 10 to 20% of the active compound reaches the lungs, and the remainder is deposits in the oropharynx. The concentration of the drug in the respiratory tract estimated to be more than 1,000 times the 50% inhibitory concentration for neuraminidase, and the pulmonary half-life is near 3 hours. Potential adverse effects include cough, bronchospasm, and other. Zanamivir administration is not recommended for patients with underlying airway disease, amantadine and rimantadine. There are active agent influenza A only. Rimantadine is 4 to 10 times more active than amantadine in vitro. Amantadine is well absorbed and 67% protein bond. Its plasma half-life is 18 hours and varies by creatine clearance. Rimantadine is about 40% protein bond and has half-life of 36 hours. Amantadine excreted unchanging in the urine, whereas rimantadine undergoes extensive metabolism by hydroxylation, conjugation, and glucuronidation before urinary excretion. In the absence of resistance, both amantadine and rimantadine at 100 milligram twice daily or 200 milligram once daily are 90% protective in the prevention of clinical illness when initiated before exposure. Side effects are those related and may diminish or disappear after the first week of treatment despite continued drug ingestion. More serious side effects, for example, delirium, hallucination, and seizures, may be due to alteration of dopamine neurotransmission, are less frequent with rimantadine than with amantadine. Both agents, teratogenic and embryotoxic in rodents and birth defect, have been reported after exposure during pregnancy. Next drug, palivizumab. It's licensed for the prevention of RSF infection, viral infection in high-risk infant and children, such as premature infant and those with bronchopulmonary dysplasia or congenital heart disease. Imiquimod. Its immune response modifier showed to be effective in the topical treatment of external genital and peripheral warts. 5% cream is applied 3 times weekly and washed of 10 hours after each application. Recurrence appeared to be less common than after ablative therapies. Imodium may also be effective against molluscum contagiosum. Local skin reaction are the most common adverse effect. These tend to resolve within weeks after therapy. However, pigmentary skin changes may persist. Systemic adverse effects such as fatigue and influenza-like syndrome have occasionally been reported. So it's all information. Thank you for your attention.